We're going to continue talking about CNS pharmacology, and in this lecture we're going to focus primarily on propofol and how propofol stimulates the GABA-A receptors, which therefore potentiates the entry of the chloride ions within the cell. And as the chloride ions enter into the cell, this tends to hyperpolarize the cell structure, the cell membrane, and therefore stabilizing the cell membrane and having an inhibitory effect on the central nervous system. This demonstrates how propofol is one of the IV induction agents for general anesthesia, and as we said, it stimulates the GABA-A receptors, potentiates the increased entry of chloride ions within the neurons, and therefore has an inhibitory effect, especially on the reticular activating system that normally has an excitatory response or excitatory neurons that are projecting to the cerebral cortex that has an activation or an alert stimulation effect on consciousness. But by inhibiting these excitatory projections into the cerebral cortex, this is clinically manifested as sedation or the induction of general anesthesia due to these IV induction agents, for example, propofol. And we'll look at propofol in greater detail, and we'll look at the structure of propofol, and we can see that there's a phenyl ring with two isopropyl groups attached to the phenyl ring at the 2nd and the 6th position. Therefore, the name is 2,6-diisopropyl. And if we look at the pharmacodynamics of propofol, the pharmacodynamics being what effect does the drug have on the major organ systems? And if we look at the central nervous system, we can see that there's a decreased cerebral metabolic rate of oxygen consumption with propofol. So the brain consumes less oxygen, and due to the decreased oxygen consumption of the brain, there's a decreased cerebral blood flow that goes to the brain. And with the decreased cerebral blood flow or the decreased blood volume within the cranial vault, there tends to be a decreased intracranial pressure. The interesting thing we'll talk about in greater detail is if you use a large dose of propofol, this may decrease your cerebral perfusion pressure due to an exaggerated decrease in mean arterial pressure. And with the decreased cerebral perfusion pressure, this may lead to cerebral ischemia. Another interesting thing about propofol is that it allows the cerebral autoregulation to remain intact. And to explain this in greater detail, we'll review the CNS physiology. And we can say that, first of all, we can say that cerebral perfusion pressure equals a mean arterial pressure subtracted by your intracranial pressure. And cerebral perfusion pressure is one of the major influencing factors for cerebral blood flow. So if your normal cerebral blood flow is approximately 750 mLs of blood per minute, and it's auto-regulated to have this blood flow between the mean arterial pressures of 60 and 160 due to the process of autoregulation, if you decrease your cerebral perfusion pressure, this may ultimately decrease your cerebral blood flow and lead to cerebral ischemia. And sometimes if you have cerebral ischemia that's not corrected, this can lead to a vicious cycle in which cerebral edema takes place and ultimately increased intracranial pressure if the edema increases. And this increased intracranial pressure may further lead to a decreased cerebral perfusion pressure and worsen the cerebral ischemia. So this is the important factor that propofol may decrease your cerebral perfusion pressure, so you have to make sure that you provide some type of pressor to prevent cerebral ischemia. The interesting thing about propofol is that the cerebral autoregulation does remain intact. And by definition, autoregulation implies a constant blood flow to the vital organ with differing perfusion pressures. For example, a mean arterial pressure of 60 has a cerebral blood flow of approximately 750 mLs of blood per minute and a mean arterial pressure of 93 or increasingly higher all the way up to 160 millimeters of mercury of mean arterial pressure, will allow a constant cerebral blood flow of approximately 750 mLs of blood per minute. If you have any other questions in regards to this, you can refer to the CNS physiology that explains all this in greater detail. But we'll continue on with propofol. And we can say that, as a review, large doses of propofol may decrease your cerebral perfusion pressure, although the cerebral autoregulation is intact. Propofol is also considered a direct myocardial depressant, which decreases the contractility of the left ventricle. It also increases your venous capacitance, means it's a venodilator, that the veins, which are considered your venous capacitance, if it's increased venous capacitance, it means you're going to have a decreased preload, which due to the Frank-Starling mechanism will reflect as a decreased contractility of your left ventricle. Likewise, there's a decreased systemic vascular resistance, which means that the arterioles are vasodilated, so that your afterload is decreased, and there's a blunted response of the baroreceptors, which does not allow an adequate increase in heart rate once the receptors sense a decreased mean arterial pressure. So all of these factors here, the decreased myocardial depressant, increased venous capacitance, which means a decreased preload, a decreased afterload due to the decreased systemic vascular resistance, along with the blunted baroreceptor, ultimately may lead to an exaggerated decrease in mean arterial pressure, and therefore that would explain why you may have a decreased cerebral perfusion pressure and may be vulnerable to cerebral ischemia. As far as the respiratory system, propofol is considered a dose-dependent respiratory depressant. The interesting thing about propofol is that it's considered a bronchodilator. So this may be helpful in certain patients such as COPD. For example, asthmatic patients, patients with obstructive lung disease may benefit from propofol due to the bronchodilation. As far as the pharmacokinetics, propofol is hepatically cleared. The hepatic clearance of propofol is approximately 1.5 to 2.2 liters per minute. The interesting thing about the liver is that it receives approximately 1,500 mLs of blood per minute, which is about 1.5 mLs per minute. But if the hepatic clearance of propofol is greater than 1.5 liters per minute, this implies that there may be an extrahepatic form of metabolism of propofol. And it suggested that the lungs may have some role in the metabolism of propofol. But propofol is primarily biotransformed by the liver through the phase 1, phase 2 reactions, and ultimately converts a lipid-soluble agent into a water-soluble inactive metabolite. For example, there are certain sulfate metabolites as well as glucuronic acid metabolites that are water-soluble and inactive and therefore can be excreted by the kidneys. The interesting thing about propofol is that the distribution, if you look at the pharmacokinetics, which implies the absorption, distribution, biotransformation, and elimination, we talked about the absorption being intravenous. Generally, propofol is painful on injection, so a lot of times people add approximately 20 milligrams of lidocaine within 18 cc's of propofol to reduce the pain on injection. Propofol tends to be a veno-irritant, so therefore it's painful on injection. The distribution, the interesting thing about propofol is that if you infuse intravenous infusion of propofol, due to its high lipid solubility it goes to the central nervous system with a rapid onset of the clinical manifestation of sedation. But once the propofol is saturated within the central nervous system and the major organ systems that receive a large blood supply, it redistributes back into the blood supply, and that redistribution many times explains the rapid awakening that takes place with propofol. And if you were to look at the 2-compartment model and the 3-compartment model, it would explain that the redistribution of propofol takes place approximately 2 to 8 minutes, and therefore a patient may wake up after a single bolus of propofol within 2 to 8 minutes time. The elimination half time takes anywhere from 30 to 70 minutes, depending if you're looking at the 2-compartment model or the 3-compartment model. We talked about the biotransformation of propofol taking place in the liver, and perhaps even extrahepatic metabolism being in the lungs, and we talked about the elimination of propofol being taking place in the kidneys.